Welcome everyone to the last speaker for the seminar series for the fall of 2020. And it's, as always, this is last but not least, as we have one of our own speakers today. And it's going to be Amy Meister, who is the Associate Chief Medical Officer at the Insurance Services Division of the UPMC Health Plan. I would ask if anyone isn't on mute, if they could mute themselves, that would be really great.
Hello.
Hopefully now muted. And Amy, in her role in the health plan, facilitates the development of innovative clinical programs for all of the health insurance and benefit management products, including she has responsibility for clinical oversight of digital and telehealth approaches. She directly supervises the medical services for the commercial and employer-facing products and provides administrative services as the Vice President of Work Partners, which I'm sure many of you who are employed by UPMC have heard about. Amy has held numerous leadership positions before coming to UPMC in 2021, and she was actually returning to UPMC because she was here before. Previous to this, she was the CEO at Level 2, where she led a creation of a digital platform focused on diabetes management for the United Health Group. And she was also previously before that with MedExpress as President of On-Site Solutions and Vice President for their employer health services. She also had a role, as I said, she's returning to UPMC. She was at UPMC before this, including as Medical Director for the UPMC Center for Hospital Medicine. Amy received her DO from West Virginia School of Osteopathic Medicine and completed a residency in internal medicine at John Hopkins. She additionally completed the Marshall Webster Physician Leadership Program at the University of Pittsburgh and the Katz School of Business. Amy brings a strong background in several important areas that I think we are all interested in, including population health management, best practices in care delivery, including virtual health and telehealth, and managed care services. And she works closely with the Insurance Services Division Program Leadership to enhance access to care and value for all members and purchasers. And I'm excited to have Amy speak here today, and specifically because when one looks at the barriers to precision medicine, reimbursement and health insurance is often up there at the top. And it's a challenge for the providers, it's a challenge for the payers, and it's a challenge for the patients. And this really isn't a simple barrier or a simple challenge. We're in a changing landscape of medical management. As one example, as we move from disease-based care to prevention and wellness, and how we are going to move that forward from the research and provider side, and then how the health insurance adapts to those new models. So I'm very excited to hear our own person, Amy Meister, speak today from benefit design to bedside. Amy.
Thank you so much for such a warm welcome, and thank you all for everything you do each and every day. It's really important work and will help guide the future of the care that we all receive. What I'd like to focus on is really to start by talking about the transactional nature of care delivery. Second, would like to cover some details on the components of a benefit design, which is more than just insurance. And a very important feature is the impact of benefit design on the entire care experience someone can have. And lastly, as Adrian focused on, how do new therapies, diagnostics, and services, how are they vetted? How are they evaluated for coverage? And what can your role be in that? I'm a big fan of history, and one of the things I find most fascinating is the history of healthcare in general. And as we talk about the why and the how we cover various services, it's important to understand how healthcare has evolved, the trajectory that it's currently on, and the health insurance industry as well. So first, about 125 years ago, healthcare was actually organized as a commodity. It was set up to be transactional, fee for service. You show up, you have an unfortunate illness or ailment, you receive those services, and you pay cash for those services. The picture on the right is one of my absolute favorite pictures from my alma mater, Johns Hopkins Hospital, from the year 1897, of which the gentleman seated is the famous Dr. William Osler, and the very curious members at the bedside are some of the very first resident physicians in the US, along with nurses, and you'll see a clipboard at the head of the bed. This isn't dramatically different from the way bedside rounds are delivered today, with the exception of this clipboard may be swapped out for some type of electronic device. Now, when we think about insurance in general, let's talk about the insurance industry as a whole. The insurance industry has been along a lot longer than the healthcare industry as an organized business. The insurance industry actually dates back to the 16th century, but was also set up and designed to be transactional. I want you to think for a moment about your auto insurance. And most of us have had auto insurance since we've been 16 years old, or when we first got behind the wheel of a car. And when you think about auto insurance, you think about the premium, and you also think about the different companies, and you shop around to see who's going to offer you the best price on an annual basis, or maybe you pay that on a monthly denominator instead of once a year, and what services are actually covered. And when you use that policy, you traditionally only would use an auto insurance policy if you're unfortunately in a fender bender, like our little cartoons up in the left-hand corner, who actually look like they're getting ready to have perhaps a fist fight and then may need to use their medical insurance. Nonetheless, when you think about insurance, these are the same things that you also will see reflected in health insurance. But likewise, auto insurance doesn't pay for preventative things such as an oil change or tire rotations. Now, in the auto industry, you also may have experienced with purchasing a new car where they're throwing in some of those services. This also isn't different from the insurance or healthcare industry, and that now you can actually buy some concierge services outside of insurance to pay for these things. And some insurance companies and some insurance products are offering various services attached to them to help make up for some of these things on the wellness or preventative side that traditionally are not covered in a transactional insurance product. Diving down into the history of health insurance began shortly after the Organized Business Association of Healthcare in the very early 1900s and late 1800s. What I find really fascinating is in 1912, Theodore Roosevelt campaigned on mandatory health insurance for all. It's been a resonating theme in many political campaigns of all sorts of races since nearly over a century ago, and we still haven't come to a great resolution. The cost of healthcare has steadily increased. It really hasn't ever decreased. And by the time the Great Depression rolled around, there began to be a focus on government-based benefits. And by the 1940s, World War II brought about the importance of perhaps actual employers providing health insurance. And by 1950s, tax credits were starting to be issued to employers that did cover some type or offer a health insurance benefit. And on the 30th of July in 1965, Lyndon Johnson signed Medicare into law. In 1980s, the health maintenance organizations merged onto the scenes to try to help mitigate some of these costs. And of course, in 2010, the Affordable Care Act was signed into law. So what is an integrated delivery and finance system like we have here at UPMC? And we've had in place since 1998. What that means is you have both the side that's delivering the care and services and the other side of the shop that's paying for them. What presents a lot of challenges, the care delivery side, from a financial standpoint, benefits from taking care of more sicker patients, providing more service. And on the insurance side, that costs more money and can lead to higher premiums that we're all paying out of pocket. And we focus on looking at, it's better for us to have a lower cost person that we're insuring than it is to have somebody that's high cost. And we want to put strategies in place to mitigate, to make people healthier. And what's really important to think about is UPMC, and some of these facts probably are like, what does this have to do with our talk? UPMC is the largest non-governmental provider in Pennsylvania with 1,000 employees and actually budgeted for close to over 100,000. Why is that important? Well, another piece of this component of being an integrated delivery and finance system is also that we at UPMC and Pitt, for those of you that have a Pitt employment, are self-funded employers. And that adds another layer of complexity that we're going to dive deeper into later on in the discussion about how benefit designs or coverage is determined. What's challenging now in the face of what's been happening with the Great Resignation, and now we're calling it the Great Reassessment of health benefits and employee well-being overall, UPMC has hired over 30,000 new employees this calendar year, 30,000 new colleagues this year alone. That's wonderful, but it also presents a bit of a challenge. When you are responsible for paying the premium and also paying the healthcare costs, it's hard to focus on and get upstream to focus on wellness and prevention and keeping people healthy when a lot of those products and services or that you may cover, you won't receive the benefit of the cost reduction down the road because that employee may churn or leave. A great example is the emergence of some of the pharmaceutical elements coming into play now. If we look at, say, the GLP-1 classification of drugs, commonly used in type 2 diabetes, but now emerging with many more indications, and most recently, about a year and a half ago, received FDA approval for the treatment of obesity as a disease. And we know if we're able to get people at a healthy weight, we can help even achieve a state of remission or reversal in a lot of other chronic inflammatory diseases of metabolism, like hypertension, in some cases, dyslipidemia, and we can prevent heart attacks, strokes, hospitalizations, costly services. The problem is, if your employee doesn't stay with your business long enough to realize those savings down the road, it can create financial challenges. The average cost to UPMC for GLP-1 drug is about $1,800 a month. So for just one medication, for one person, we would be writing out about $20,000 a year. It's a lot of money, but it definitely has the capabilities of creating a much healthier lifestyle, a much healthier person, but that's a long-term investment. So there are a lot of tactics and features now to really focus on how do we keep people as employees? What do they want? What can we do to help make UPMC and Pitt employers of choice so people want to stay here and we can invest more on the front end, like a portfolio investment, in our long-term health? The last number on this page that I want to call your attention to is in the bottom bullet, that with the health plan, we cover nearly 4.5 million lives. And why is that important? What's important about that is over 60% of those covered lives come to a UPMC related facility or service to seek care. And that's money that we keep within the system rather than paying those dollars external to the system. What does an insurance plan look like? An insurance plan, your insurance card that many of you have either on your phone or in your wallet, probably looks a lot like this and has some very simple facts to it. It likely doesn't have your total premium, but it would have things like your coinsurance. Your coinsurance is the amount of dollars and cents that you're responsible for paying after you've met your deductible, which is the amount you have to achieve prior to kicking in. Now, many employers, and depending whether you're Pitt employed or UPMC employed or another employer, can determine certain types of wellness interventions like take a healthy step, participating in healthy challenge, to buy that premium, buy down that cost share, if you will, or the dollars that you have to spend prior to having that coinsurance kick into gear. Copay is the amount of dollars that you pay at the time of a visit. And your network is information about what types or what providers are covered under your plan. Now it's time to get into the anatomy of a benefit design. A benefit design in itself is more than just an insurance plan. An insurance plan is just one tiny element of what really can dictate or mandate or show what products and services you can receive as a consumer of healthcare goods and services. The second bubble over you'll see is ancillary insurance. This is dental and vision. And at one time, this also included behavioral health, but now majority plans, including ours, include both physical health and mental health services on one plan. Hopefully, the evolution of health insurance will include these other ancillary services on one plan too, to help eliminate confusion. Next would be your pharmacy plan that covers prescription drug. The bullet over is probably one that you might be really questioning. What does this mean? Enhancements. And this is becoming the bigger bucket of services and often can be confused as to whether something falls into the enhancement bucket or the actual medical insurance bucket. So what's in an enhancement bucket? Enhancement buckets are services, products, experiences that employers will often subsidize, or sometimes insurance carriers themselves will pay for to help make their benefit, one, more attractive, and two, help achieve the goal of getting people healthier, so more focus on wellness. Some of these things include things like workplace flexibility, caregiver services, tuition reimbursement plans, lifestyle accounts where you can choose perhaps a gym membership. They also may include various point solutions for various disease management programs that you can receive additional care that's outside of your regular care delivery assets, that's at no out-of-pocket costs. And next would be financial security. Many health benefits are married to some type of health savings account, retirement account, or medical spending account. And this all put together equals your benefit design. But yet it even gets more complex when you think of some of the duplication. On this Venn diagram, what you'll see is the medical insurance, pharmacy benefit, well-being, and care delivery. Most of these assets have their own app, their own monitoring devices, disparate scheduling, different engagement tactics, and a lot of feedback that I've heard in my career in insurance, both at UPMC and outside, is I'll hear feedback from people that are on the insurance plan that sometimes they'll get a call from one of these 4 elements and not understand, is this a scam? Is this really part of my insurance product? Is this free to me? Or they'll have conflicting coaches. They'll have a coach from their doctor's office call and someone from their well-being benefits call, and really not be coordinated. So what's the advantage of an integrated delivery and finance system? We have a very unique opportunity to figure this piece out. How can we have a concerted effort to where you don't have a kit of parts, but you have one front door to all these products and services that are streamlined and really kind of match.com to you personally? How can we personalize whole person care in a meaningful way? And outside of these products and services, there's also things like workers' compensation, short-term disability, long-term disability, and FMLA that also play a role. And what we have discovered is when we piloted connecting these services, we see a 70% increased engagement in our wellness and coaching services when you enter through one of those atypical doors into the healthcare ecosystem. Now, to answer the question of how is it determined if a new precision medicine item is covered or not, it really comes down to who pays for health insurance. And most of us on the call would say, well, I do, of course, which is definitely correct. However, there's some nuances to this. According to the CDC, greater than 90% of our spend of 4.1 trillion in healthcare is really on people that are living with chronic physical and mental health conditions. So it certainly makes sense if we could find a way to bend the trend and get out in front of those before they become a horrific spend. There are really 2 areas that we want to focus on separately to answer those questions. One is the governmental branch, and the other would be the commercial branch. When you're in the governmental bucket, think of Medicare and Medicaid. And under Medicare, one of the big hot things that you've probably seen in the news articles lately are Medicare Advantage plans. So why so much excitement about Medicare Advantage? Medicare Advantage are governmental funded programs that allow somebody with an insurance license to resell or manage a population at risk, and they're paid a fixed amount to do so. So the healthier they're able to manage that population to, the more dollars they're able to keep. or reinvest into their products and services to help them manage their population. This is largely flooded with a lot of private equity dollars currently. However, many of the companies out there are really struggling to remain profitable. So, and as to the efficacy of Advantage plans, you'll find research out there that support both sides of the argument, quite frankly. However, we would like to think that the additional enhancements and services that you're allowed to provide to recipients of Medicare Advantage plans enable them to live healthier and to age well in the home. Next would be Medicaid, and under Medicaid would be the managed Medicaid products. And on the commercial side is where we have a lot of variability, and allow me to give the nebulous answer of it depends when it comes down to coverage. Let's think of this in two separate large categories, as in employer and individual. In the employer bucket, you have two subcategories of fully insured and self-funded. In the fully insured bucket, that is where an employer comes to us, to a health plan, and gets a policy much like you do when you go buy that car policy or auto policy, that they pay a premium. So regardless of how much health care that a covered person receives or utilizes, the employer pays one price. And the insurance company is really at risk for making sure that person is as healthy as they can be and to help control their cost or spend. A self-funded employer like UPMC or Pitt is much different. They are subject to different governances and rules of what you can and can't do. However, largely, they really help direct and dictate what they want covered on their unique benefit plans. We're going to go into more detail, and I'll give you some more clarity on that in a few slides. And on the individual market, this is where you hear terms of like healthcare.gov or Penny, the marketplace. There's off exchange and on exchange. The simple difference between the two, it really comes down to if you are eligible to receive either tax credits or a subsidized plan, then you can get your insurance on the exchange. And if you don't meet that, then you can go to healthcare.gov to select a plan. We're seeing an increased trend nationally that some employers, self-funded, are not providing a specific option for benefit plans. Many times they have more than one carrier in place, of which we call it slice business, or they're just providing a lump sum of money that you are required to spend on healthcare and saying, go to the exchange, pick what you want, what's best for you and your family. When we look at a deeper dive into the commercial marketplace under the employer sponsored, you have small groups and large groups. Not a significant difference there, although some of the fully insured larger groups will go ahead and opt to buy enhancements that we talked about on top of the core benefit or insurance product to help support the health and well-being of their employees. And the self-funded, you may have heard them also referred to as administrative service only, or ASO, or TPA, third-party administrator. And in that case, what happens is your employer is actually the one that's on the hook for paying your bills when you go to see a provider. And the responsibility of the insurance company is to negotiate networks so that the employer is getting the best price in healthcare services that they're buying. A self-funded employer, for the most part, can make some decisions as to new therapies, products, and services they would like to specifically cover. However, this is looked at and governed in the state of Pennsylvania. For example, the PID, or Pennsylvania Insurance Department, would oversee some of these things, and they have to be in compliance and in harmony with several other legal and regulatory issues. So in other words, a self-funded employer could not just go out and randomly decide to cover the most all specific research elements or items or new therapies and services from one particular provider and not cover them for other providers as well. And the healthcare marketplace, they've tried to simplify this. There is a lot of competition in the marketplace, and it's all a game of about premium. That's reflective of what your population is in terms of how healthy they are and who's using those insurance benefits. They've eliminated a lot of the confusion by saying you have to have one of four designs, and they're all related to metal. So you either have a bronze plan, a silver plan, a gold plan, or a platinum plan. And what you'll notice, the more precious the metal, the higher the premium, but the lower the out-of-pocket at the time of the transaction when you go to receive care. Many times, those that are the sickest or have the most intense health needs will purchase the highest premium because it's like breaking up over time their healthcare costs rather than having a low monthly paycheck deduction. And then when you go to the provider or get your services, have to pay at that moment in time a lot higher costs. With these types of insurances, there are some rules that we have to follow, and you have to have at least 10 essential health benefits. And I want to be clear, I'm not going to read off all of these benefits, but what's clear about this is that we are required to have a coverage policy. It does not mean that as a carrier, we're required to cover them at no out-of-pocket costs. The no out-of-pocket cost usually is on the side of preventative services that are an A or B rating from the U.S. Task Force on Prevention or something that is put out by AHIP. When we look at Medicare and break it out into the traditional product, which is still the majority of the U.S. population, but not by far over the Medicare Advantage, there's some differences. First, with traditional Medicare, there's Part A and Part B. Part A is covered by your hospital benefits. Would cover things like your hospitalization, hospice, and home health. Part B would cover things like the doctor's office or durable medical equipment and tests. Part D covers drug coverage. And Part C is what we call Medigap. One of the most common things you've probably seen advertisements for are AARP. I've seen a number of advertisements with sports heroes talking about why you need these incremental policies to cover for additional spend. On the right side, you'll see Medicare Advantage, and this is what we're calling Part C. This really combines Part A and B, and usually even Part D, the prescription drug element. And these folks are not eligible for Medigap services. Every month, you may have paid attention in your own paycheck that you'll see a Medicare tax deduction. Well, that tax funds Part A. It does not fund Part B, C, or D. Those are all funded through monthly premiums, deductibles, co-insurances, and copay. Lastly, we'll cover what is medical assistance. Medical assistance is really a partnership or collaboration between the state and federal governmental agencies. And these have very specific guidelines as to who is eligible for coverage. Very strict income or disability guidelines. One fact that I wanted to share that's really a myth is that folks that are on Medicaid don't work. The reality is 60% of those that receive Medicaid actually do have an employment of some sort, whether 42% are full-time and about 19% are working part-time. So how am I judged as an insurance company? Who regulates me on the job that I'm doing? The number one is really customer satisfaction, and that's really seen by membership. If we're losing membership, we're not doing something right. If we're gaining membership, we're doing something right. When it comes to quality, NCQA and STARS are two agencies that really oversee a lot of what we do. The higher, the better. And I wanted to spend a minute on this because this also reflects some of the future of when you talk about moving away from fee-for-service or transactional care to bundled care and to really moving the needle on quality. This is where, as an IDFS, we also have an opportunity to really excel and figure out the math. What's a challenge for most places and why the needle to move from fee-for-service to value has been so challenging. There's only $1 to share when it's distributed to a health plan for meeting a quality metric. So for instance, if I see a PCP, a cardiologist, a gastroenterologist, how do I carve up that dollar amongst them that are all working to provide excellent care to make me healthier? That's the challenge. And that's where we, as essentially a capitated system at large, being both a payer provider, should be able to really figure that out. And we will be working hard over the next several months and years to get that roadmap in place, to really figure out how we can get to that true value-based experience for all of us. Under cost management, The metric is per member per month, that we look at how much does each individual member cost on a monthly basis. How many services are they utilizing? And we have a lot of metrics in terms of on the insurance side of looking at utilization, which can create a lot of frustration on the provider side and the sense that there are hoops to jump through and barriers. But those are there for a really good reason at large. And I'm going to talk a little bit later about when do we kind of do away with some of the utilization metrics and gold card, if you will, various providers or services to no longer manage them because they're being prescribed appropriately and yielding the right value to our customers, who in this case are members of the insurance plan. I'm going to spend some time talking a little bit about what's called medical expense ratio. MER is the UPMC term. Outside of here, you may hear it called MLR, medical loss ratio, or MCR, medical cost ratio. And there's a lot of magic here because this is the area that really determines really how much we all end up paying ultimately for health insurance. Medical expense ratio really takes into account what is paid in healthcare claims divided by what is collected in healthcare premium. The Affordable Care Act defines how much of that dollar is actually required to be spent on paying claims and quality improvements versus what you can keep as profit or overhead. Excuse me. And what's important to note about this, these ratios are defined by the governmental agencies and determined very clear. And let's say we do a really good job of managing people and making them healthier. That creates more dollars that we will then return back to those who have paid premium because of doing such a good job in managing their health. And here we go from bench to bedside. How do we actually get a service, a product, particularly when we're talking about some of the greatest innovation along precision medicine and personal care? How do we get that to where it's part of our benefit design, where it's part of our insurance policy? We do a number of things at the health plan to help inform us. First is a market watch. By market watch, I mean we survey other insurance policies. If Highmark's covering it, there's a greater possibility that we would also cover it, along with other carriers. We recently launched a really cool tech program that continuously surfs the web and looks for information related to medical policies, new things on the docket from a regulatory environment in Washington that will be voted on to help us also understand and be prepared in the future of things that we will be required to cover or will need to find out how to cover. As many times it's beyond not just thinking about how to cover something or when we cover something, but it's making sure that our systems can appropriately adjudicate a claim for that particular item to make sure that when you get a bill that you have the appropriate amount of responsibility. The next two buckets are not exactly one and the same, but very similar. Does coverage put us at any compliance risk? Or does not covering it put us at a compliance risk? And when you move into regulatory, there are many items that come down from both federal and state regulators that you are required to cover. And many times that coverage is sometimes stated as to how much member cost share or how much you have to pay as a healthcare consumer out of pocket for that particular product or service based on what type of category it's placed in. Next, we have a complaints and grievances department that we review those complaints and grievances. And many times those are things of members reaching out saying, I need this service. Or many times it could be a provider writing in saying, this is ridiculous. I always need this service. I always need this test. And why should I have to go through this process? We review those very, very intently and then put those through a process to determine what should we now consider covering based off the volume of complaints and grievances. And we look most importantly at scientific evidence. Is there good peer-reviewed literature out there that supports new therapies in us covering them? Whether that be a diagnostic test, whether it be a scan, whether it be a procedure or a medical device. What's the evidence to say that this this is going to improve outcomes, improve morbidity, mortality, or decrease the total cost of care ultimately. With utilization management, we have a lot of steps in place to take a look at what do we always say yes to. And when that's the case, that's when we often go down what we call more the gold carding process, and are able to eliminate additional hurdles and hoops to just allow something to occur. We also look at what we deny heavily to determine if there were issues or concerns, or certain providers or types of providers perhaps, or maybe even a place of service, that something is being ordered and administered incorrectly or against what would be considered a standard of care. We also have a robust Department of Health economics here at the health plan that review each and every potential element that we want to cover to really have that risk benefit equation of what's the cost, what's the quality outcome, and really help us make decisions based off of data as to what's the best path forward. And lastly is the line of business considerations. By line of business, specifically meaning what insurance product, because, and this is where I see probably the most confusion, we may cover something under, let's say, commercial, an ASO client or two want a particular lab covered that Medicare doesn't cover. And so when you're thinking health plan in general, remember, although we are one health plan, we have several products and services of which the coverage determination will be different for each individual product. How do we make a medical policy? So medical policies serve a couple of purposes. One, they help keep us accountable as to when we're receive an audit or reviewed by any governmental agency, they can take a look to make sure we're adhering to our own policies. And then we also have pay policies that tell us when we should or shouldn't pay for various types of services. And when doing this, it's no different than any policy, whether it's in or outside the insurance agency. We gather input, we draft and develop policies. And when we're doing this process, we have a very robust medical policy committee that we're very proud of. And particularly, many of you may actually participate on this committee because it's not just about people in the health plan. It's largely made up of our subject matter experts that come from our larger health system. And additionally, we bring in providers from external places of service as well. So that way we can get a nice voice outside of UPMC and inside of UPMC. And those experts that are delivering care on the front lines really help inform and help us determine whether something should remain as what we call E&I, experimental investigational, or do we actually put it into coverage policies? Example of some of the market watch inputs I've described earlier, but something to think about would be some of the governmental reports that come out, annual rulemaking on the federal and state side of the shop, and internal policies. What type of new policies and procedures are coming out on the health services division? What new research or innovative topics? These are things that we love to stay abreast of, and invite you, if you aren't sharing them, please send me an email, let me know what's going out. We want to know the latest research that's out there, because this can help accelerate our ability to be first to market in covering some really unique products and services. Additionally, we spend a lot of time making sure that we're mindful of proposed legislation and how that will be required or architected into future plans. We also need to use a lot of our technology to help support these efforts, and are working for solutions. You heard me reference the new tool that we have to kind of surf the web to make sure that we're identifying new policies and procedures as they come out from our competitors. Lastly, what is the future for us all? The future for us all is really a great opportunity to help. We want to provide care for vulnerable populations. We want to solidify whole person care as the new normal. We want to get away from this transactional fee-for-service architecture that historically both insurance industries and care delivery were built on. But it's not so easy, and it's not a one-step process. We as an organization, meaning all of us together, will be working very closely, particularly now over this next year, in coming out of the pandemic, to really think of how can we work to get to that high value, high care, being first to market? Those are all very important things to us, and we have the ability to do this. And if you've watched or followed any of the news, you'll see, unfortunately, independent health systems now are really struggling financially. It's very, very hard for them. And so we are lucky, being that we have the insurance component that's doing well, to combine together to be able to solve what's happening right now in healthcare. And I want to invite each and every one of you, your intellectual capital, the amazing talents that you bring, as I opened up with, are so very important to help us solve what's the next iteration healthcare system look like? How can we really be innovative and design a new health system? So the next generation giving this talk won't have a picture of somebody lying in a hospital bed with a clipboard over it. They'll show what we do today as being a momentum of the past. We need to lead the way on the convergence of consumerism and healthcare. Some things that you will be seeing very shortly. On 1/1, it will be going live, the 500 shoppable services. So what is this in the insurance industry? As an insurer, we had to disclose what fees we pay for services and where. So as a consumer, this will be available to you. You can go online and you can pick any test. You can pick any service that's listed in those 500 shoppable services for starters, and you can shop them just like you would any other service on Priceline.com or some of the other hotels.com or Expedia for travel services. You're going to be able to do the same thing for healthcare services. So that's why it's more important now than ever. The dollar isn't going as far as it used to. We need to make sure that we are financially sound for the future as an organization, but doing so in a very responsible way, and that each and every single one of us can get value out of the dollars that we do spend in healthcare. And most importantly, that we can bend the trend and get to the point where we are attacking population health, that we are tackling disease and resulting in a healthier population to get out in front of the astronomical spend that we've witnessed over the evolution of healthcare to get it to where it's at today, and health insurance. So at this point in time, I'd like to say thank you and open it up for some discussion.
Amy, thank you very much. That was fantastic. I will clap on behalf of everyone because everyone is on.
Thank you.
And Jenny, if you could unmute everyone, that would be great. We will open it up for questions. Maybe I can start with the first one, because there's one in the chat, and I'll ask that second because I think it comes back. That refers to this last point you made about these 500 units you can look at and then purchase. But for the first one, I was wondering about these astronomical costs, because obviously, as we move towards precision medicine, one of the goals is to give the right therapy to the right patient at the right time and reduce waste and overtreatment. But some of these precision medicine treatments are extremely expensive. CAR T therapy, some of these gene therapies. How do you, and they're not getting cheaper, how are you envisioning controlling those costs? Because they're outstanding and they're saving lives, and they obviously, a lot of them are curing people lifetime. How is that going to get embedded into the system?
That's a great question, and there's no simple answer. I don't think we have a great answer, and that's where I'm calling all talent to help us solve that collectively. We need an answer, and I think part of the solution is figuring out how can we take as much administrative cost as possible out of the system to be able to streamline the services and products that we are delivering. And precision medicine is a great way, and the principles used in precision medicine to actually get there. And yes, it is costly, but I am optimistic over time we'll figure out how to compress that cost. And I think that comes from competition. That comes from emergence of more companies doing different types of precision techniques in the marketplace. There's a long runway, as you know, and I think some of the challenges come from how we have to get therapies approved first through the FDA and all those hoops and hurdles. That timeline has got to be compressed to help us get costs down. So a lot of it will start in Washington with regulations that need to be put in place. And from there, we need to get creative on how can we, one, demonstrate the long-term value and get buy-in and investment from our self-funded sector to help support this, because a healthier workforce that doesn't migrate from job to job to job, I'm convinced that that can help pay for a lot of these technologies investments that we need to make today.
The second question that's in the chat, which I think a lot of people wonder about, and you mentioned this we're on this seesaw of the provider and the payer, where one is somewhat antagonist to the other. If we do more on one side, we hurt the other. And you mentioned this. How is that balanced? How do you see that being balanced then?
So that's also an area that I don't think I would say that I would yet call us super successful, but we're going to be, and here's how. We are now talking about how do we come together, and I will say the collaboration this time that I've been back at IPM is so much greater than it's been in the past, to where we've been willing to at least put our grievances on the table, and that's really important. We have to understand the why on both sides, and we have to listen and be willing to work collectively to a decision. Many times what I've seen in the past is that we're all passionate about our whatever jersey we're wearing, whether we're on the health plan side or on the provider side. We're very passionate about what we're doing because we're helping people, we're delivering care. So how do we come to a compromise? Because for many of us, a compromise means we're not doing a good job on providing a care or service or treatment or outcome. How do we get there? And that's where I think it's really important that we grow a little bit thicker skin, bring all these things up, and we sit down and figure it out together. And if we don't have both sides of the shop at the table to figure this out together, if it's just dictated or mandated, it won't work. And I think the key to all of this to be successful is really a technique that when I was out and about with my United Healthcare and Optum days, one of our clients always kept, and if you've ever seen The End of the World or some of those shows out there, kept a volleyball in the middle of the room, and it had a patient's name on it. And it wasn't a real patient, but they always kept that in perspective, that what we're going to talk about today, it's all about the person in the middle. It's not about our own personal beliefs that we often color our opinion or our actions on. It's about that person that we're trying to solve for. And how do we do that? And if we were that person, how would we want the experience to be? So if we can anchor to that person level experience, I think we'll solve a lot of our problems quicker.
And I'll move down to the bottom of the chat, because this is a question I hear quite a lot. And I don't know if you know the answer to this, Amy, but what ability to do research on claims data and clinical data like EMR data for the UPMC patients? I think I should know this answer. I get asked this a lot. And what's the resources we have for researchers to do that?
We have phenomenal resources, actually. Even within the health plan, we have a Center for High Value Healthcare that can help, and we love to go out and work, get for Corey grants and others to try to look at various elements. One of the things that I live and breathe by, I'm a data geek at heart. I love data. I love living and breathing data that can help inform decisions as well as actions. And we use a lot of tables. We have a really unique asset here at UPMC that I want to take a moment to brag about, because even at Optum, which is known nationally for being a data mega house, we didn't have this capability. We actually have within our data warehouse, within the work partner shop, we have the ability to not just bring in medical claims and pharmacy claims, along with some EMR data as well. We actually have the ability to bring in the work comp, stop loss, and human capital component. So you start calling off work, for instance. Think about the predictive. So some of the predictive models we've built are focused on, wow, someone starts having a lot of unplanned absence. Well, why? And can that predict things like not just turnover, but maybe they have diabetes or hypertension that wasn't treated. And we're seeing a lot of success with that. So I'm really excited about that ability for us to take that human capital side and marry that to medical and pharmacy claims. I haven't seen that anywhere else in an automated fashion. And I think there's just so much for us to study and learn there. I get so excited every time I play in the data warehouse about a new dashboard that I want to generate.
Cool. So I will read this one out. And so if people want to do that, what's their entry to the health plan to do that? I'm not going to give out your email address. Do they go to the Center for Healthcare?
I think I reach out to the Center for High Value Healthcare, or by all means can reach out to myself, Dr. Schuster. We're more than happy to help provide that conduit, because it's so rich and can provide so much information to us. I think it's really important.
So I'll read out another one. I heard of pending legislation that would reduce PCP payments for Medicare, in turn for commercial ones as well, and in turn forcing PCP visits to 10 minutes per patient, which won't provide a sufficient systematic care. Do you have any thoughts on this that you'd like to share?
Sure, my thoughts are that's awful. I'll just sum that up in one simple word, is that I recently read another article that I love time studies. And it showed that the average PCP needs to spend 27 hours a day that only has a panel of 2,000 patients to actually take care of them. So clearly there's not 27 hours in the day. I've also had the experience to work in what I'll call a unicorn practice. The practice that I had previously was a full actuarial risk, which is where the secret sauce lies. If you're able to own the risk, the whole risk, then you're able to do things like you don't have to bill the patient for a telephone call. You get paid for really all the work that you do, whether that's looking at an email, whether that's and doing some really cool stuff. So for instance, when I was in a full risk environment, one of the most unique capabilities I had was the ability to send through a secure chat, a YouTube style video that half the screen I'd go through an x-ray finding or a continuous glucose monitor report, describe what that was. And I would send a YouTube style video that I studied. 2 minutes or less was really the time span that people would had to watch those, to the members. The average watch rate was 8 times. People would share them on social media. It's their information to share. It was shared via HIPAA secure portal, of course. So I think there's an appetite. And as a care deliverer myself, from primary care perspective, we can do a lot of really cool things. And it's the fee for service and the RVU component, the way we're paid, that stands in the way. And that's why I really want to work heads down, fast and furiously, pencils up, figuring out how do we get there faster, particularly when we are essentially global, UPMC, where we already are capitated. We own the payer and the provider. So we can't let these things happen.
So from John Meyer, a relatively similar question that follows on from that, and I think this is in your area of wellness. So how might revenue flow to an ambulatory primary care office that is focused on prevention and is busy delivering better health to the patients cared for by the office, when that does not involve dropping bills for procedures or tests? This challenge. What's your thoughts on that?
We actually provide, as a plan, several resources through our value-based. We have a lot of shared savings initiatives, but absolutely, we provide a lot of services in the community. We provide practice-based care managers. We provide that do connected and coordinated care, because the physician and the advanced practitioner providing service doesn't have time, and nor should they. We want them working to top of license. We don't, or top of scope of what they desire to do. We have to be smarter about who's doing what. We can provide a lot of services, everything from pharmacy services, medication adherence, medication administration, and we do this already. It's just a little known secret that often folks don't know that we provide or do as an insurance plan. And it's not just us as a plan. Other plans outside of UPMC offer services as well. We like to try to stay ahead of the market and do more. So if someone is doing something we're not doing, please let us know by all means, because we certainly want to be best in class. And as we move more towards that value-based, we can embed more services in the provider's office. The last thing I'll say on that topic is we're working right now to re-engineer what can we do in the home. We want to help people age well in the home. We know not everybody is digital savvy, so how can we kind of cross that digital divide? How do we address social determinants of health and bring a sense of equity into everybody that we care for? We're focusing heavily on these initiatives now to find ways that we can work with communities to even provide training services. We're doing some unique programs like providing handymen in the home to help take care of some safety hazards that lead to healthcare costs down the road. So there's a lot of opportunity in partnership with the payer, We're just looking for ideas and a way to execute.
Yeah, I think John was also asking from the bigger IDFS system, and I think there's another question from Ann Thompson, which is very similar, is how do we recognize the time MDs spend with pre and post visit work that takes hours beyond the time in the clinic, which is similar, I think, to what John's asking about when you're doing these preventative services, which don't have so much revenue. How could the system be altered to make that more valuable to our system? Because that's value-based healthcare, yeah? Absolutely.
So I think, again, the answer is we've got to get away from RVU payment, and we have to get away from the transactional nature of healthcare. When you put that aside, you can absolutely do those things in a very comfortable and have a very comfortable practice that's not, not your entire life, that you can have a personal life too, but without changing the way we pay providers and the way that we reimburse for services, we're not going to be successful in doing that. It's critical that we change the trajectory of the way we do that for a number of reasons, but most importantly, if we want to get there to where we can offer these smattering of services and that providers are really truly paid for the work that they're doing, we have to get away from fee for service for the point and click or the point and shoot approach to care. And the last thing I'll say tied to that is that I firmly believe, because I've practiced in a practice like that I'm describing, so I know it's a reality, it can be done. You have the ability then to you start often spending more time up front with the patients, but you can demonstrate significant ROI and significant savings and outcome improvements. And that's really the way to prove that it's the right thing to do and it's sustainable over time. If you're able to move the needle on total cost of care by these things that providers have to do to really do a good job of managing their population that, quite frankly, as I know and everybody on the call is aware, don't get reimbursed today.
Yeah, and there's a lot of people on the line who are doing, you mentioned this specifically, innovative approaches in precision medicine at Pitt and UPMC, and thinking about reimbursement. This is obviously always a compelling question. So one of the questions which relates to this is, how does the bench to bedside coverage process work when the patient is seeking access to a previously approved treatment for a new application as compared to a de novo therapy? How is that handled?
Sure, that's a great question too. And the answer is, again, it depends on the product and service, but traditionally, if it's, I'll just call off-label or for a new indication or new use, if we haven't approved it through our gauntlet of processes, I would encourage the provider or the patient to reach out, and that's where we can approve on a one-off case. Now, of course, that's when we review the complaints and grievances in our fraud, waste, and abuse logs. When we start seeing that we're approving a lot of things as an indication that hasn't yet been globally covered, that's when we start thinking, oh, okay, well, now it's time to put this in policy for everybody. It is a little bit more of a painful process, but it is possible.
And I think I've read most of them out. If anyone wants to ask a question, I'd be happy to open it up. We're heading up to the end of the hour, but if anyone wants to ask a question, that would be great. I know I've peppered. There was lots of questions in the chat and I've missed a few, so I was peppering Amy with them. But if I've missed someone and they would like to speak up, they're happy to. If not, Amy, that was fantastic. As Amy said, she offered her email address as a way to contact her. That was really great. I think it was, as I said, reimbursement and payer coverage is a major part of precision medicine. As you pointed out, I think it's really great that we work together in the IDFS to try and create a solution. Thank you, everyone. Thank you, Amy.
Thank you so much. I appreciate it. Everybody have a great evening, and I look forward to hearing from each and every one of you.
Okay, you heard that. Bye.
Thanks. Bye-bye.